In the interest of time, we'll move on. Let Dr. McCloskey, if you could give a brief overview of the FLT3 data that you have. Thank you.
Yeah, I'm happy to. So, as we mentioned, it's been an exciting couple years in AML, but the RATIFY trial, looking at the addition of midostaurin to induction and consolidation chemotherapy in newly diagnosed patients was really the study that resulted in our first FDA approval. And again, this was de novo AML patients between the ages of 18 and 60 with a confirmed FLT3 mutation. Patients on this trial were risk stratified according to their FLT3 mutation, but it did accrue patients with TKD mutations as well as ITD mutations, and then further risk stratified based on allelic burden. And in this case, the cutoff for risk for high or low was 0.7. This trial was a tremendous effort on the part of many investigators, and over 3,000 patients were screened, with eventually 717 patients being randomized in a double-blind fashion to either midostaurin or placebo. Midostaurin was combined with induction cytarabine and daunorubicin, with midostaurin being added on days 8 through 21, 50 milligrams twice daily. For any patient who achieved a CR, they were then eligible to proceed on with a stem cell transplant when that was available, and likewise, until that point, continued on with consolidation with high-dose cytarabine in combination with midostaurin, added again days 8 through 21, 50 milligrams twice daily. Importantly, I think after this, patients were eligible for a maintenance arm of the study. Patients were not randomized to maintenance, and in this context, midostaurin was administered 50 milligrams twice daily, continuously, days 1 through 28. So if we look at the breakdown, the characteristics of patients accruing to this trial, patients had a median age around 47, so fairly typical of in keeping with the patient that we just discussed. And they were well stratified, as we discussed, in accordance to their subtype of FLT3, whether it be ITD, TKD, or a low or high allelic ratio. When we broke down responses in those patients, we did not see a difference in CR during the first 60 days. So CR rate was around just over 50% in both arms. When we expanded it to look at CR during induction or consolidation, including patients then that subsequently achieved a CR after coming off study, there was a favor, the trial did favor midostaurin with a 66% CR rate compared to 59% in the placebo arm with a p-value of 0.045. This improved CR rate and the use of midostaurin resulted in an improved median overall survival. So 74 months in the midostaurin arm compared to 25 months in the placebo arm. And again, I think, especially at the time, this was super exciting data. It took us decades to move those curves. So lots of things added to 7+3 that had failed to separate those curves over the preceding decades. Many patients treated on this study did proceed to stem cell transplant, and that remains our standard approach for these folks. And if we look at outcomes based on those patients who underwent stem cell transplant, we saw that the greatest benefit to stem cell transplant and survival in the midostaurin group was really seen in those patients who went to transplant in CR1. And then this kind of gets at our question about how do we approach these patients with FLT3 mutations based on their allelic ratio. And midostaurin is a pan-tyrosine kinase receptor, so we talk about it inhibiting FLT3, but it actually hits a variety of other receptors as well. So I think it's particularly relevant to our discussion about thinking about the type of FLT3 mutant patients we might select. But the bottom line was that all patients on this study really benefited from midostaurin. And if we look at survival based on subgroup, TKD patients benefit, as did patients with a low allelic burden. So I think based on that, we really can't yet use allelic burden to kind of decide whether or not midostaurin should be added to those folks as frontline therapy. And I think the other thing that was really exciting about this study was that it demonstrated that we could safely add something to 7+3 without getting a lot of unexpected toxicities. So if we looked at grade 3 and 4 or 5 adverse events, we really see that we didn't see a significant increase in infectious complication or myelosuppression. Really the only thing that fell out of that was an increased risk of rash, which I think most of us who treat AML feel comfortable with if we're getting an improved efficacy. With that in mind, we'll touch briefly on another FLT3 inhibitor, gilteritinib. And currently in our commercial use of this drug, this is for patients with relapsed and refractory disease, but I think we're going to continue to see expanding indications for these FLT3 inhibitors in both the upfront and potentially the upfront and the relapse setting. So the ADMIRAL study was a phase 3 randomized study looking at patients with FLT3 mutant AML that were relapsed or refractory. So just over 300 patients accrued to this study, and they were randomized in a 2-to-1 fashion to gilteritinib versus salvage chemotherapy. And there was really a variety of chemotherapy options for that standard arm. So we included low-dose cytarabine or hypomethylators for maybe patients who were more frail, as well as intensive salvage therapy, including cytarabine-based regimens like FLAG-IDA or MEC. Again, the primary endpoint of interest in this study was CR rate and overall survival. At any point a patient had a remission and appropriate donor, they could proceed to stem cell transplant. And I think this is an interesting model, again, because it raises the idea, the potential for us to use a targeted agent in salvage instead of high-dose chemotherapy. And in fact, when we looked at the results in this phase 3 study, we show that they favored the use of a molecularly targeted therapy. So the response rates were almost double for the gilteritinib group compared to salvage chemotherapy. So if we look at responses, the CR rate in the gilteritinib group was 21% compared to 11% in the salvage chemotherapy group. CRH, 34% compared to 15%. And more patients treated in the gilteritinib arm were able to proceed to stem cell transplant, 26% compared to 15%. And all of these improved responses, again, translated to an improvement in median overall survival in the gilteritinib group, 9.3 months compared to 5.3 months. So again, I think an exciting era where we're talking about a molecularly targeted therapy with significantly more appealing side effect profile than chemotherapy.